So Dr. Lamis will be talking about two subjects, I guess. The optical recognition method for deep anterior lamellar keratoplasty described by Melles, and Bowman layer transplantation. But allow me to introduce her. She is an anterior segment surgeon and consultant at the Else Institute in Zurich and at the University Eye Hospital Münster, Germany. And she is very specialized in lamellar keratoplasty techniques, especially DMEC. And she also worked at Netherlands as a cornea surgeon and head of academy for almost 7 years. And now she currently is finalizing her PhD on allograft rejection and graft survival after DMEC. You are welcome, Lamis, and we are ready to hear you.
Yeah, thank you very much. I will just share my screen first. I think you can see it now, right?
Yes, clear.
Okay, thank you very much, Nancy. It's really nice to get to know you like this. I hope we will meet one day in person. And I thank the organizers and of course, Anas, it's always nice to work with you. You're so kind, and thank you for the introduction, Nancy. As you already said, I will speak about two topics. Actually, I was asked to speak about the Melles DALK technique, and we thought it's a nice thing to show you that we have combined this DALK technique recently, or it's actually not so recent. It's like 10 years ago when this technique has been developed, with how we work with Bowman layer transplantation for advanced keratoconus cases. These are our financial disclosures, which are not related to this talk. And I want to start to show you that Gerrit Melles is always very innovative about how to think of new techniques and how to simplify a technique actually for himself as well. And so he thought, maybe if I put air into the anterior chamber, then I can see better how I dissect the cornea, because normally you would not see the posterior surface of the cornea because of the little error difference, refractive difference between the endothelium and the aqueous humor. But if you put air, actually you can produce an interface that is more visible. And if you put an instrument on top of your corneal surface, then this produces it's like a convex mirror, as you can see here on the left side, and it produces two images, two virtual images. And the interesting image is actually the second one, because if you indent the cornea in a way, the distance between the first and second image that is produced is halfway your corneal thickness. So this is how you benefit from the air in the anterior chamber to visualize your dissection depth better. And this is what happens, because when you put your instrument to your incision, you start seeing a reflection here, which is created at the interface, and it's producing like a dark band. And this dark band becomes smaller the more you advance into the cornea. And this is what was useful for doing this kind of dissection technique, because the thinner this dark band becomes, the nearer you are at the descemet membrane, and you want to become very near to the descemet membrane for the DALK technique. So to dissect hopefully 95% depth, for instance, to then produce the viscodissection, as you heard earlier. So here you see this indentation effect that you have by pushing your instrument into the cornea and producing this kind of dark band at the interface between the air and the endothelium. And here you see the dissection depths you can get by doing so. So you can be at 60%, 80%, and if you are very lucky, you get even to 99%. Dr. Melles produced some spatulas together with DARK, actually, to perform this dissection. And I want to go through this dissection together with you. Here you see, first you need a scleral tunnel, and you fill the anterior chamber with air. And then actually you take the first spatula and start to go to through the stroma. And the further you get, as you can see here, the further you get, this dark band becomes smaller and thinner. And this is where you get nearer to the decimate. And then you use the second instrument, which is a proximal dissection. So you start dissecting the whole cornea in the proximal part of the patient's eye. And you do that very carefully, trying to stay in the same plane as you have already chosen for the depth you have done. And finally, you use a second spatula, which is a bit larger and goes through the whole corneal surface so that you can dissect the distal part as well. So then you have the 360 degrees of your dissection. So here a little video on this. So first you start with your scleral tunnel to open, then you make a paracentesis, put the air, and then you start finding your dissection depth. And if you look carefully here at the tip of this instrument, you can see like a little dark area. And this area is the dark band that should become thinner and thinner the more you progress and advance through the corneal stroma. You use some dipping of fluid so that the interface does not fill up with blood. And then you advance further. So now you have reached the depth you want. So it's quite near to your decimate, and you take the second spatula and carefully, bluntly dissect. And here you see still the lines around this instrument. You carefully dissect the proximal part of your cornea. You have to be careful because, of course, you have a lot of scars in these patients often that can be quite deep. So you have to be careful not to create a tear. And here, this is actually just the marking of the center. You remove the air and you put some visco in the pocket you have just created to detach the decimate with hopefully just a little bit of stroma. And after that, you can put on your trephination. And these steps you know, of course. So I will move further. You just saw that this is dissected the pocket. So just remove it and then you knit in the donor. So what we do here is that we use this technique also for a new technique for keratoconus treatment, which is a 60% depth. So you don't want to just go to the decimate, but you want to stop at the midstroma to do a so-called Bowman layer transplantation. So this is the PK. This is the DALK, and I have to say this is an inlay isolated Bowman layer transplantation because our colleague Dr. Isabel da Pena is just publishing a new technique, which is an onlay, but this talk is based on this midstromal pocket and midstromal insertion of this Bowman layer transplant, which is unfolded inside this bluntly prepared pocket and stained with trypan blue and then unfolded inside this pocket. And I will later on explain to you what the idea behind this is. So this is Dr. Melles, and he invented or created this surgical technique in 2010. So, and published the idea of putting this stromal, this Bowman layer into this pocket, because the idea was that in keratoconic eyes, you often have these changes in Bowman's layer, which usually is a layer that keeps the cornea in its shape and keeps it firm. It is acellular layer, which helps to support the whole structure. So the idea was if you would implant a Bowman layer in a patient that has a weak or keratoconic cornea, then you could actually try to stabilize this kind of cornea. So, and the idea was, of course, it was created in a time when there was, of course, cross-linking introduced, UV cross-linking, and we had some kind of contact lenses and scleral lenses, but it was a time when we still did not know how to treat thin and very steep corneas. So for these eyes, there was not a solution yet, and therefore this technique was suitable to think, okay, we have an eye that is progressing, but is still having a good vision with some lenses, but is too thin to perform a UV cross-linking or receive some rings for intrastromal rings. So therefore this technique was created, because though these eyes have quite good outcomes with DALK and with PKP, we still have young patients that will probably outlive this transplant, and they also may have some kind of ocular surface problems that may increase with a repeated transplant over their life. So this is the patient group. The idea is just to halt the progression and to preserve visual acuity, to have a safer treatment option for these kind of patients, and to postpone those techniques that are good, but still more invasive than this kind of technique, because it preserves your ocular surface. Of course, if you want to think of a new technique, you have to think, how can I produce some kind of graft like this? So therefore, I just brought you a little video, which I will go through quickly. But important for you to know is this graft preparation is done in the NIOS by our expert in this, Esther Groeneveld, who nicely prepares those grafts. And it's quite time consuming, because if you already incise too deep into the stroma, you're already dissecting a too thick Bowman layer. And this Bowman layer usually forms a roll just like a DMAC graft. And if it's too thick, you will see that it will not roll like this anymore. So this is a small video about the preparation. You can see here, if you have seen the incision already, how you incise it, then it's already too deep actually. So here you see how she's lifting the edge of the Bowman layer graft, and now she's pulling it. You have to do that very carefully. Even though this tissue is quite stiff, it can still produce some holes, and therefore you have to do that very carefully. So here you see how you do that over 360 degrees, and I will move it a bit further so that you get an idea. It takes quite long, and at the beginning it took even longer than it takes her now. So you see, you have to do that quite careful. What we try is to use a large graft as much as possible, because I will show you later in a surgical video why that is so important to have a larger Bowman layer graft and not just to take the center. And here I move it further, and you see how it goes on slowly. Often we are asked how to implant this transplant. We just implanted the same way, like it lay down in the cornea. So we would implant it the other way around, like we would implant a DMAC. A DMAC, you normally have the rolls up. So this one rolls like this. So you will just transplant it the same way into the pocket, like it would lay in a cornea. Okay, so this is how it looks like then. You make your scleral tunnel, just for you as an overview. You make the lamellar dissection that you've just seen, the same one as with the DALK Melles technique, but in the midstroma, so not so deep. Then you make the proximal, the 360 degree dissection. It's all a blunt dissection. You put an inserter, a glide into the pocket. You stain your graft, which before was synced into alcohol so that it removes all the cells. And then you put the graft, and this is quite a longer part, and I will show you now the video. So here again, you have the scleral tunnel, and then you make the paracentesis so that you can put some air to create your optical effect, and also to shield your eye, because these are phakic eyes, so this is useful to have air between your dissection plane and your patient's lens. And here you saw the small instrument that found the dissection depth, and now you take the proximal dissector, do the proximal part, and again you can see the line around the around the instrument, which indicates for you how deep you are in the stroma. And then you take the larger 360-degree dissector.
Dr. Lamis, I'm afraid that time is running, so it's only 1 minute left.
Yeah. So then you put the glide in and the graft, and finally you unfold it, and you have to stiff it into the pockets so that it's inside. This is how it lies in the eye, and we see a flattening of these corneas and therefore less progression over time. And this brings me actually to my last slide already. And it's a different technique. It's a controlled dissection technique. It uncompromises the anterior and posterior corneal surface. You have a graft that is acellular. You're postponing some kind of other surgery, and you're using this technique to also efficiently use your donor tissue. Thank you very much for your attention.